Hello, welcome to the special Facebook Live event, COVID-19 and ITP, our virtual town hall with global ITP experts, presented by the Platelet Disorders Support Association. I'm Caroline Cruz, President and CEO of PDSA. At PDSA, we know that easily accessible resources and accurate, reliable information are always critical in living life with ITP. We also know that during this unprecedented time, patients and caregivers managing ITP have and concerns related to COVID-19 and their condition. Earlier this week, during a call with members of the International ITP Alliance, the president of the ITP Association in Italy, which is the epicenter of the pandemic, said something very profound that I would like to share with you. She said, now healthy people understand the fear and anxiety that people with chronic conditions like ITP live with every day. Fear and anxiety around the unknown every day. This is why PDSA was founded, and this is why we are hosting this town hall today. Although COVID-19 has heightened the stress level in managing an already overwhelming condition, our goal remains the same: to provide life-saving information, resources, and support. Remember, you're not alone. We're all in this together. I would like to thank the sponsors of this event, argenx and Dova Pharmaceuticals, along with the small but mighty PDSA staff and PDSA medical advisor, Dr. James Bussell, who were able to pull this event together in 3 days. In less than 24 hours after sending out the notice of this event, we had over 700 registrants from 44 countries around the world, 48 of the 50 United States, as well as Washington, D.C., Puerto Rico, 7 of the 10 Canadian provinces. And that doesn't include the thousands of others watching live on the PDSA Facebook page right now. If you can't stay for the entire event, we will have a recording available on the PDSA website for later viewing. And if you're a member of PDSA, we will share highlights of the Q&A in our quarterly newsletter, The Platelet News. I'd also like to thank my co-moderator for this event, Dr. James Bussell, who has gathered some of the world-renowned ITP experts along with other top experts to provide some insight and answer your specific questions related to COVID-19 and ITP. We have compiled a list of those questions sent to us by patients and posted on this Facebook page, and we'll continue to take some of your questions. And now I'd like to turn it over to Dr. Bussell to introduce our panelists.
Thank you very much, Caroline. It's been a great pleasure to work with PDSA on this, since I think this is a very important issue to discuss. Very quickly, I think we need to give thanks to all the frontline and support workers involved in caring for patients and supporting those who are caring for patients, for all that they do for us overall. I also think we have to consider what the ASH ITP recommendations are. They have a page of frequently asked questions on COVID-19 and ITP. Before I tell you those quickly, prior to introducing the participants, I just want to mention that while the epidemic is in full swing, and we know that many, many people, more than 1 million around the world, are infected, and many have died, we also know that from the point of view of understanding the virus and understanding what different medications, how they affect it, both to make it better or to make it worse, is very uncertain at this time. And it is very tempting to think that you read something or hear something and that that's a real nugget of truth. And it's just important to recognize how preliminary it is. And we all know that many of the things we give opinions on now may be found not to be true later. So we're all going to do the best that we can, but please recognize that this is a very fluid, very rapidly changing situation. Some of the questions regard patients with ITP who need treatment currently, not necessarily those who are COVID-19 infected, but who are worried about the risks. Dr. Holland will discuss this in more detail, but the general idea is to avoid medical facilities whenever possible so that you don't get an extra risk of being exposed. And for now, the medical advisors for ASH, many of whom are medical advisors for PDSA also, would think that the thrombopoietic agents are probably the safest. IVIG would also thought to be safe and helpful, but if you have to spend a day at a medical facility to get it, that adds some downside to it. As far as concern about splenectomy, we do not believe at present, but I'll be interested to hear more information from some of the speakers, extra risk of splenectomy in terms of COVID-19. In general, we believe the risk of splenectomy revolves around encapsulated organisms with carbohydrate. What can be confusing is that a COVID-19 infection can create a fever. And therefore, we think that if a patient who has had a splenectomy has a fever, they should be handled according to standard guidelines and given antibiotics. With all that, I would like to turn the program over to our first two speakers, Dr. Steve Holland and Dr. Charlotte Cunningham-Rundles. I believe that Dr. Holland is the leading infectious disease expert probably in the world, certainly in the United States. If one were to go to the NIH hospital, then we would find out that, sorry for the papers, we would find out that he is taking care of patients that nobody else anywhere in the country can take care of, and he is sorting out complex situations, making diagnoses, figuring out treatment. I think he is amazing. To be fair to him, he is not a virologist, but I thought because of his general experience and background, he would be able to tell us about the virus in a very patient-friendly way. Before turning the podium to him, I also want to introduce Charlotte Cunningham-Rundles. Full disclosure, Charlotte and I are married. Charlotte is one of the leading, if not the leading person caring for immunodeficient patients in the United States and the world, and could be well able to address the issue of immunocompromised patients, how much immunocompromised is immunocompromised, and what happens, but she will primarily be answering submitted questions. Steve, over to you.
Thanks so much, Jim, and thank you for that very kind introduction. Let me just say that I have the great privilege to work at the NIH with Tony Fauci, who really is the world's great infectious disease doctor and is doing an extraordinary job providing top-notch information to top-notch people and trying to make sure that all of the world hears what we know about this. So I want to take just a few minutes to talk about the virus and about some of the questions that people have about it that Jim has outlined. And I want to just begin at the very beginning to acknowledge what Caroline pointed out. It's very scary to have a risk of dying. And it doesn't matter whether that risk is one that you were born with, that you acquired, or you heard that it's around the corner with coronavirus. It's a big deal and it is frightening. And that fear makes the uncertainty of how we deal with treatments and with responses very, very difficult to deal with. And this webinar to try and deal with fear and deal with uncertainty and to get facts out there is critically important. I could not be a bigger advocate. So let me start by saying This is an RNA virus, and it's called a coronavirus because of how it looks. It's got a little crown around it. And although up until 3 months ago, all of us thought that a corona was a beer, now we know it's a lot more difficult. And the virus, there are other viruses like this. You've heard of SARS, you've heard of MERS in the past, but this is one that arose and was identified first in China and has now spread all around the world. It's not a regional problem, it's a global problem. Because it's a virus and because it is encapsulated inside of the membrane that it takes away from the cells it infects, it's not actually that tough to kill. It's not that tough to kill in the environment. And the way it spreads is that it's caught in the secretions that we cough out or sneeze out or occasionally speak out. And it is the spread from our oral secretions that's really important. It's not carried up in the air. It's not floating around. It's in that stuff that comes out of us, and it usually falls to the ground within 3 to 6 feet of the time it leaves us. And this is why this whole advocacy of social distancing is so important. Just getting us to spend a little time further away from each other. In the United States now, we're finally following the advice of many other places, which is to use more masks. Masks are being used to prevent us from transmitting virus to other people. The typical masks that we wear aren't going to protect us from getting infected. They'll prevent us from spreading the infection. And if we stop it from spreading, we protect all of us in the long run. Let me just talk for a minute about what the testing is. When you hear people say that they're going to get tested, right now the testing means that somebody's going to stick a swab into your throat, get some of the secretions there, and check to see whether the virus is present. And that's a test to see, are you actively infected? And that we'd call a direct test or a nucleic acid test. What's coming down the road and just has been approved and will be, I'm sure, out quite soon, are tests to check for antibodies. That is, to see whether you were ever infected with this virus. You know, antibodies are what mediate many forms of ITP. That's what drugs like rituximab are trying to target. And those tests have not been in general use yet, but they will be very soon. So you want to remember the difference between direct testing for the nucleic acid and antibody testing. The direct testing tells you, do you have it right now? The antibody testing will tell you whether you've ever had it in the past. Now, I know that for many of the people on this call, the big question is there an increased risk with ITP? And the simple answer is, I don't know. And because ITP comes, occurs from many different causes, I suspect that the understanding the risk will depend on why you in particular have your kind of ITP. They're not all treated the same, they don't all respond the same, and so I'm not sure I could tell you about risk, and I suspect Charlotte has a lot more information about that. One of the other questions is, how is this like the flu? Well, you know, the sad truth is that we lose 30 to 60,000 people a year to flu in this country. 30 to 60,000 people die each year from influenza. And we have a hard time getting people to get vaccinated against that. The bad news is that this disease is about 10 times worse than that. So about 0.1% of people who get infected die of influenza. And right now, most estimates suggest that up to about 1% might die of getting infected with this. Although that sounds like a small number, 1%, it's a pretty big number when you start talking about whole cities or whole states or whole countries. And so we're desperately trying to make sure that we get this addressed. So this infection spreads more readily and is more lethal than regular influenza. Let me talk for a minute about treatment. Treatment is what we all want. We all want to know that when we get sick, we can take care of this problem. And there are a lot of treatments being tried right now. And the only way to know what treatment works is to do it in a trial. If we say we heard about it on the internet and we're going to go do it because what can it hurt? I'm telling you, if you don't do the right thing for the right reason at the right time, it can hurt. There is no such thing as no big deal when it comes to serious illness. So right now there are randomized prospective trials going on of a drug called remdesivir, which blocks the virus, and those trials have gone on around the world and should be done relatively soon, we should know. There are trials of plasma, so people who had the infection, who got over it, their plasma is being taken and given to people, and that plasma contains antibodies that can fight the virus, and we should know very soon whether those are effective. You've read virtually everywhere about hydroxychloroquine and azithromycin, and I just have to remind you that so far there are no solid data that suggest that those things are helpful, and we know that at least hydroxychloroquine can be harmful. So please consider joining a prospective trial if you feel like you want to be a part of that. Vaccines are, in the long run, our great hope, and the vaccine trials are already going on. They were initiated several weeks ago. We're coming to the end of the first phase. There are vaccine trials now in several countries, and I'm very hopeful that we'll have solid information in a couple of months that will tell us exactly which way to go and which vaccines to be building up to use. Finally, let me talk about the major complication of this disease. Of course, it's terrible to feel bad and to feel like you've got the flu, but many of us have been there and we've all gotten over it. What can happen with this infection is that the infection can cause severe inflammation in the lung, and that inflammation in the lung can lead to inability to breathe and therefore the need for a ventilator, or it can lead to death. The way that that's being treated sometimes is by blocking the inflammation by very potent anti-inflammatory drugs. And this raises the question of exactly what's the role of inflammation in the development of severe respiratory failure. And so it is in theory possible that people who have defects in inflammation or people who are getting anti-inflammatory drugs might be protected from some of these long-term complications. So right now, I'd say the jury is out about exactly how ITP interacts with this infection and how anti-inflammatory drugs interact with this infection. Right now, there's no guidance that says you should stop taking the medicines you're on without talking to your doctor about it, and no guidance that says you should not take ibuprofen or any other drugs that you're on to try and be ready. So I'd say this is where you need to talk to your doctor. I am absolutely confident that with the amount of work that's going on, which is extraordinary, the amount of work going on, we will have good answers coming up soon, and we are very aware of how painful this period is, but I promise that all of us are working very hard to get through it. I'll stop there and be happy to take questions in the question period. Thank you.
Thank you very much, Steve. Caroline, do you want to start the questions?
Yes, well, Dr. Holland, you touched on the antibody testing. So for patients out there who aren't quite sure what antibody testing means, could you give us a little bit more of an explanation on that?
Sure. The antibody testing is done on blood or saliva. And remember, antibodies are what your B cells make that bind to infections. So antibodies are developed against the virus, and we can test for those by taking your blood and looking to see if you have a particular virus. If you have responses, that suggests that you were infected and that you mounted an immune response against it. We think that if you have antibodies against this virus, you are probably protected from it, and that means that you're probably not at risk for getting it again. I'm saying probably because we don't yet have full evidence for all of those things, but in general, when you have an antibody against something, like what you get after a vaccine, that is what leads to protection.
Thank you. And I know that many patients are on IVIG to treat their ITP or have been on IVIG at some point in time, and they're very concerned whether the COVID-19 virus can be transmitted through IVIG.
Well, I'm sure Charlotte can expand on that more, but I have zero concern about the COVID virus being transmitted through IVIG. Absolutely zero.
And yesterday, the FDA updated their guidelines. There is an urgent need for blood, but I would like to share with our community is that there is a great need for plasma, and that's different than making a regular, going to your American Red Cross and making a regular blood donation. You need to go to a plasma center to donate plasma. And there is a great need for that. My husband actually went twice within the past week, and he was telling me, extraordinary precautions that the plasma centers are taking, that patients are at least 10 feet apart. They have the doors locked when you go in. Everybody is in protective gear. So if anyone in our community, other than patients who currently have ITP, would like to make a donation, it would be to a plasma center. Dr. Busey?
Good.
Yeah. Do we have Dr. Cunningham-Rundles on yet?
We do, if you'll open my, okay, great. Sorry. Charlotte, why don't you tell us about IVIG and the plasma supply, and not only about what else would go on, but whether it might have any protective effects also.
Right. So the first question is something which I just got some data today, which is that Florian Kramer, who's been testing for neutralizing and otherwise binding antibody to the COVID in lots of gamma globulin, we've tested somewhere around 25 or 30 different lots and products, and the results are zero. So that sort of raises the question of, well, is it of any use at all? And I know that it was published recently in a British journal that 3 patients treated in China with high-dose IVIG did quite well. And of course, that's totally anecdotal data. As Steve said a moment ago, these patients were not treated in any randomized way. I don't think it's clear whether it was working because it was neutralizing or because more likely it was simply an anti-inflammatory situation. So those of us working in the world of primary immune deficiency look at that data and get a little bit concerned, because of course that means that people might be using gamma globulin when it would probably be soaking up supplies for patients who actually require it for life. So that's the first comment with regards to that. The other comment is to answer the question about the transmissibility, which we have had that question. It actually did come up, and it's a published statement from the International Patient Organization called IPAPI. And the data from that comes from the PPTA, which put out a very specific statement stating, and published in February the 17th, and it's available online, coronavirus and plasma therapies. And it appears that it's not transmittable, and studies have been done to indicate why that would be the case. So I think we can all feel pretty relaxed about that. From the standpoint of the patients, of course, we're very eager to have them go ahead and take their regular treatment. I know patients are always concerned going to an infusion center or having a nurse come to their home, but our patients in the main, I think, have been quite willing to continue that therapy.
Charlotte, can I ask you and Steve what may be a little bit more of a difficult question? I think many ITP patients think that they're immunocompromised, either because of having ITP or especially because of treatments they've received. Could the two of you maybe talk a little bit about the redundancy in the immune system and say anything that you might know about whether, for example, rituximab, steroids, and other agents like azathioprine, Imuran, or mycophenolate mofetil, whether those have any effects that might make people more susceptible to the virus.
Well, I'll take a starting place. As you probably might realize, I'm basically an internist, but I have a pediatric appointment as well. So we do cover Manhattan, Brooklyn, and Staten Island for a newborn screen for babies with severe combined immune deficiency and the other diseases that come in the door with low T cell numbers. So that's part one. Part two is that I currently see somewhere around 600 patients with hypogammaglobulinemia and write orders for at least half of those. The other thing is I'm also the infusion director for Mount Sinai's Non-Cancer Infusion Center. And in that center, we give biologics to patients with rheumatoid arthritis, inflammatory bowel disease, lupus, transplant situations, psoriasis, basically anything where you're using an immunosuppressant to calm down an autoimmune or immune deficiency state. Of course, we give a great deal of gamma globulin as well. And looking at my numbers, you know, the honest truth is that we have, amongst my own patients of that large set that I just told you about, I actually, on my own, have one patient who has this virus. So I'm puzzled by that because I would have thought that I would have been just absolutely mobbed. But the truth of the matter is that I personally have one. One of my colleagues has another patient who has had a very severe form. And the only patient in the infusion center, which, by the way, I have to mention, does somewhere around 500 infusions per week. So that's 2,000 per month, or 2,000 patients per month. Of that set, we've only had one patient have this virus infection, and that's a patient who had a kidney transplant and is on a medication called belatacept. So I think I'm waiting for the other shoe to drop, because you would have thought that I would be in the middle of a vast number of cases. And for some reason, so far, I've not been. And of course, that could be easily that the patients that I know and the patients that I would take care of and those that are immunosuppressed are just incredibly cautious. And that may easily be the case. It could also be that we simply haven't seen it yet. We will be seeing that moving wave come toward us, and it simply hasn't landed upon us yet.
Steve, do you want to add something?
I would just echo what Charlotte said. You know, we're not sure exactly how all of those immunosuppressive and immunomodulating drugs affect susceptibility to the virus. Remember that you're talking both about the virus infection, which in and of itself is not that big a deal. It's the complications of the virus infection that we really are caring about. So we don't know yet what's going on with people who are on all these immunosuppressive agents for sure. What we do know is that we'd love not to find out. We'd love to make sure that people maintain the social distancing and the caution that many people who are already on immunomodulating drugs practice. And this is the time to redouble your efforts and make sure that this period of social distancing is successful, because that's how we can stay unfamiliar with the kinds of complications that Charlotte and I are so worried about.
Well, we have lots of patient questions, and we're going to try to get to as many of those as possible. And Dr. Cunningham-Rundles, welcome. Thank you for joining us. I have a follow-up question for you. As a person who no longer has a spleen, and I know there are lots of patients out there who have also had splenectomies, are we considered immunocompromised, or are we at greater risk should we get COVID-19?
I think we end up having to assume that a person with no spleen is to a certain extent immunocompromised. But remember, somewhere around 50 of my patients don't have a spleen either. So I don't, you know, as I say, I haven't had anyone have an infection yet. So it's extremely hard for me to make a case for that. The only patient I was particularly concerned about actually Steve, I don't know, maybe you'll have a comment about this particular one, is a patient who was on a inhibitor of interferon. This is a patient with a STAT3 mutation, and he's in school. And this is one that I was very concerned about because I would have thought that would be a bad situation. So far, so, not a problem. I don't have very many patients with that particular immunosuppression. But Carolyn, your question was really about splenectomy, and I think the data on that is completely out. I honestly wouldn't have projected that as being a particular problem myself.
Yeah, I agree with Charlotte there. I suspect that splenectomy is not that big a risk for this particular infection. It's overwhelmingly a lung infection and does not seem to have a major bloodstream component or a major circulating effect. Doesn't mean it couldn't have some, but I think the real thrust of its complications are in the lung, and so I bet that splenectomy is not going to be a major determinant here.
Thank you. And Dr. Bussell, would you quickly like to talk about if a patient, an ITP patient, has a fever, what they should do, what important steps they would need to take immediately?
Thanks, Caroline. I think what they would need to do would have nothing to do with the COVID-19 situation and be all true for any person who had ITP or had another issue and had a splenectomy. Ideally, they should get antibiotics immediately and go to an emergency room and get IV antibiotics and be assessed. Most of the time, they will not be very sick, but the small percentage of the time that they will, when they may have a bacterial infection, could be very serious. But this would be standard practice, and I think people would be quite aware of it. Caroline, I would like to shift the order. You may have seen that I sent you an email because David Cooter said he would have to leave the call at about 11:55. So I was thinking we could go to him next, if that's okay with you.
That would be great. Hi, Dr. Cooter. Thank you so much for joining us. I know you're really busy there in Boston.
Well, I'm not as busy as New York, but we are bringing out old people like me to take care of patients in the hospital right now, which is quite striking. So it's a new era for all of us. But again, I've heard part of the conversation so far. I've not had a huge overwhelming trouble with any of my ITP patients so far, but we're at the beginning of the curve here. And as others have spoken about, I don't regard most of my ITP patients as being terribly at risk for having susceptibility to this virus. But as Jim Bussell just said, if our patients have temperatures and no spleens, we do worry about them.
Dr. Cooter, do you think it's important I know here in the US, patients who've had a splenectomy do not take prophylactic antibiotics, but in the UK they do. So would it be important for ITP patients here in the US to get on an antibiotic during this time period?
Well, that's not been my practice. None of this is evidence-based medicine by any means, but it's not been our practice to do that, Caroline. I think one of the things I will put a plug in for, but it may be something it might be a bit late, is I think all splenectomized patients should be up to date in their vaccinations, which I've encouraged all of our patients to do over the years. So I think that to me is something that's important for this patient population. But again, I don't think having no spleen is going to put you at increased risk for having a viral infection. I do think that if one gets a super infection with a bacteria, a pneumococcal bacteria, for example, then this absence of spleen and no vaccine might put you at risk.
David, Caroline, is it okay if we switch gears and ask David another question, even though we might want to go to Nikki about the splenectomy antibiotics once he finishes?
Sure, we only have Dr. Cooter for a short period of time, so go ahead, Dr. Bussell.
That's why I was thinking that. One of the issues, as you know, David, is to try to get people to use Nplate if they're on it at home. And I know that you seem to have had special success in Massachusetts, and I think in Italy, where Dr. Rodigero is, and certainly in England, they can use Nplate at home when they get their patients to qualify for it. Could you say something about how you were able to do that and why you think it's not more universal in the United States?
Well, again, I think right now that for Nplate patients or for ITP patients in general and a TPO receptor agonist, the first thing to say is that people don't need a platelet count every week. They need a platelet count maybe once a month or so, and many of my patients get platelet counts every couple of months. Most of our patients we've designated as healthcare providers by just saying that they're healthcare providers by having taught them how to do a self-injection. So that's gotten past the FDA statement that you've got to be a healthcare provider to give the medication. And so most patients get a prescription, which we, having designated as healthcare providers, take the medication at home. But there are still some of our patients, particularly Medicare patients, where that's still not easy to fly. And most of those patients will get a platelet count drawn once every month or two and then come in for a brief visit to some clinic in one of our outpatient facilities and get their injection and get the hell out of there. So we make our current patients who are getting injections in our facility go to one of our outlying centers where there's less of a wait. It's like a fast track, and you come in, get your shot, and you get out of there. So we're trying to minimize their exposure time outside the house. But most patients can get this drug approved for home injection just by discussion with their healthcare providers. And these days, that's become even easier. It's also a plug, and I'm not here to support any other company, another plug for oral agents over a sub-Q injection once a week.
Dr. Cooter, I do have a follow-up question about that, though. If someone is on Nplate and they're doing really well, I mean, we know all TPO agents aren't made the same. So is this really the time that they would want to try to switch to something because, and then potentially have a crash, which would end them, which would end up in the hospital?
Yeah, I'm not saying people should switch. I'm saying that right now this is an argument long-term for people being on oral agents if this becomes our permanent way of life, which I hope it won't be. But I think right now people shouldn't switch all of a sudden. But I do think right now that the need for platelet counts on stable therapy is vanishingly uncommon. This drug does not need to be changed in dosage once every week like many centers do. That's silly.
Yeah, and I think you bring up a really good point because we are hearing from patients who are having to go in every week to get a platelet count, not specifically on Nplate, but just on other treatments.
That's unnecessary. That's unnecessary to actually dose adjust patients on any agent, TPO agent. I think unless you're a very unstable patient, that's not necessary, and it creates problems. So most of our Nplate patients who are getting it either at home or in the clinic, we draw their counts once every month or two.
Would you talk about the importance of symptoms versus platelet count?
Yeah, you've got me on this is a long lecture. This is a 2-hour lecture, but I promise I won't give it. I think right now, I have many patients who live at platelet counts of 8, 15, 20,000 and are stable, have minimal bleeding or bruising, and many of those patients don't need to be treated. I also think that one shouldn't worry about high platelet counts, particularly if patients occasionally go to 400,000 and the rest of the time are at 120,000. So I think that one has to be very careful about what your target range is for a platelet count. As I said, many patients live a fine life and a stable life and a safe life with platelet counts of 15 to 20,000. And other patients, physicians go crazy when the platelet count goes to 405,000 for no clear reason.
Can we, Dr. Cooter, can we go back to the question of immunosuppression? We've had many patients ask, how long are they immunosuppressed if they've been on steroids or rituximab, for example?
Well, I don't think we actually know the answer to that question, Caroline. I think that the patients on steroids, the immunosuppressive effect of steroids has never been fully studied in my understanding. And, I think if you're on a low dose of prednisone, say 5 milligrams or less chronically, that's probably not a very immunosuppressive dose. But patients who've been on high doses of 60 or 80 for some period of time, I would imagine that effect will last for many months after the drug is stopped, since the lymphocytes get depleted for sometimes many months after that. The same is true for rituximab. The lymphocyte depletion may last for 6 months after that medication is given. But again, I haven't seen an influx in our hospital here. We've got almost 300 patients in our hospital with COVID-19 infection right now. I've not seen an influx of any of our immune suppressed patients coming to the hospital.
I think another big concern for ITP patients is if they do get the virus, will it drop their platelet count?
I think, again, I have no experience so far, so none of my patients have gotten infected, thank goodness. Maybe others can comment better upon that, but any viral infection, CMV, for example, or EBV, or even a cold will commonly drop platelet counts in many patients. Paradoxically, about 1 in 10 of my patients who gets a viral infection, the platelet count actually rises, so I don't understand that. But in general, viral infections drop platelet counts. It's probably because it turns off the rate of platelet production.
David, could we ask Nikki to comment on that last question, because I know she has experience, and Francesco, maybe you could comment afterwards if you've had experience with that. Nikki?
Okay. Okay. Can you hear me?
Yes.
Oh, hey. Yeah, we have had a few patients relapse, whether it's the COVID related to it or it's just coincidental, I don't know. I had one patient who relapsed and responded very well to IVIG. He's one of my patients who typically just relapses every viral infection. He's had a very fluctuant course anyway. And another patient who has relapsed and is now an inpatient with COVID-19. I think that we are very heavily infected in London at the moment, so it may just be coincidental, so it's hard to say. I have reached out to our other European colleagues, and certainly Mark Michel and Francesco Zaya haven't seen lots of relapses in ITP. I think we also, on the aspects of immunosuppression, does that increase your risk or not? And like Charlotte, we have not seen lots of patients who are immunocompromised coming in with severe COVID disease. I'm not sure, I'm not convinced at all, that it seems a risk factor for the severity of the disease. And certainly within our hospital, we don't look after just ITP, but it's a big hematology, big renal group and a big rheumatology group. So we would have anticipated seeing a lot of patients by now. And that hasn't happened. Again, whether Charlotte's, these patients are isolating well or not, I don't know, but I'm not convinced that immunosuppression is a big risk factor for the severity of the disease that we see.
Francesco, do you want to comment?
Yes. First, thank you for inviting me. Very interesting. I just yesterday did a survey among the major centers in Italy by phone to understand about any patient with ITP and the COVID-19 positivity to the swab, and no one has apparently such a patient. So for the moment, despite Italy is severely hit by this pandemic, there are no patients with coincidence of infection and ITP. In general, all major centers agree that the major risk for ITP patients now is to be outside their home, to have exposure time outside home. In Italy, during the last 3-4 weeks, we have a complete lockdown. No one can work or go outside home unless a strict required personal need, like go to the pharmacy or to purchase food, something like that. And the effort is to reorganize the management of patient using phone, email, or direct address to the lab where the patient has done his platelet count to look for the value and then call back and give advice. This is for those patients already on treatment. For new patients, the general feel is that it's better to use an oral available TPO, mimetics, instead, for example, of M-plate, to avoid the need to often check the platelet count or instruct the patient for injection in a healthcare facility or in hospital. So the major effort is to keep patients outside any hospital healthcare related facility and to manage the patient by phone. The second is to be relaxed about platelet count by saying that on the average, in the not very elderly or at-risk patient, having platelet count down to 15, 20,000 per microliter is not a significant risk of major bleeding. So tolerate also this level that otherwise will need an adjustment of the dose of the corticosteroid, the few that are using, or the TPR receptor agonist. And this is the major aspect. If the patient has some emergency need or has a major bleeding, of course, he or she will be hospitalized separately from the risk places of COVID-19 infection. And about a word about splenectomized patient. Many splenectomized patients phone to the centers, to the doctors, asking about their risk, and they are informed that there is no major risk of being infected, having your spleen out. The suggestion, as anticipated by Jim and by David, is that in case of fever that do not remit, we in Italy don't use prophylactic antibiotic treatment. But so for Italian patient, if there is a fever that does not remit promptly after parental, possibly in treatment with beta-lactams antibiotics, they need to be admitted to an emergency room or to a clinics to have hemocultures and to have a surveillance, a strict surveillance, because we know that a low, very, very rare, less than 1%, a very rapid development of septicemia can occur in splenectomized patients, particularly if these patients have not been revaccinated or vaccinated in the last recent years, let's say in the last 5 years. This is the only, let's say, particular advice that we give to splenectomized patients. We have no knowledge of any of the many patients in Italy. Currently, we have data on 150,000 patients that are positive. None of this is an ITP patient.
Wow.
Oh, I've got to go in a second. Can I make one final comment?
Please make two final comments.
One of the things that I would encourage, many patients do need platelet counts or blood counts checked at some stage. So I think that's an issue that has to be dealt with. Many patients, and I would include myself if I was a patient, are reluctant to go to major medical centers to have blood counts drawn. But we've set up in our community of, I shouldn't say hospitals, clinics, centers, fast tracks for blood draws for a lot of hematology diseases. So many of our patients will pop out of the house, go fast track, get a blood count drawn, and be back in their house in 20 minutes, having have their bloods drawn, and are almost totally isolated from anyone but the blood drawer who draws their blood. So I think I think most patients who need blood tests done, I think can be done safely, usually outside the major medical centers.
Thank you, Dr. Cooter, and thank you so much for your time. I know you're really busy, so thank you for being with us. And I should mention Dr. Rodgeri is actually from Verona University in Vicenza, Italy, of course, the epicenter of the Corona-19 outbreak. And Dr. Nicola Cooper is in London. And Dr. Cooper, because PDSA has an international audience, we did receive a number of posts from patients in the UK saying that they had received a text from the NHS saying that they were considered high risk, immunosuppressed. Can you tell us anything about that? And then the second follow-up question is, in the UK, you do give prophylactic antibiotics for patients who've had a splenectomy. So I'd like you to comment on both of those questions.
Yeah, so I think things that the NHS decided to do was create a list of people that they thought might be more vulnerable to COVID-19 than other people, so that they could protect themselves more than the general population. And it was, I guess they did it fairly rapidly. So I think that a lot of people were contacted who were not necessarily vulnerable. So I think it has been quite a scary thing for people in the UK to do that. I think we have tried to respond to Julian wrote saying the ITP support associations can be directed that, and we're following up with phone calls for lots of our patients and hopefully following up with better advice for them. And I think it was just a quick response to try to make sure people were not unnecessarily exposed to the virus. I don't know if that fully answers it. The message also came through our GP network, so it didn't come from the hospital. So that's the way that the NHS decided to contact people. So I think it has created some confusion on that. And I think it certainly does feel like we are learning that perhaps people aren't as vulnerable as we thought from immunosuppression. And I can't remember the second question, Caroline.
It was just about taking prophylactic antibiotics.
Yes, so that's the UK advice to carry on is penicillin regularly, and I agree with all of the discussions that have been had before. I think certainly it's really important to make sure we are treating secondary infections, so any bacterial infections do need to be treated, not just in the splenectomized patients, but other patients. And I think that's really quite important in the sort of COVID-related things. And back to sort of Francesco's point, I'm just thinking I think we certainly do have a few patients who've had ITP around COVID-19, so interesting that it's different to Italy, but again, I guess we're learning a lot more about the disease now.
And Dr. Cooper, for those patients, I'm reading a number of questions that people are sending to us right now. Do they have a higher risk of dying if they have ITP, or more complications if they have ITP? And do we even know at this point?
No, I don't think we know any of that at this point. I think that it's exactly what we're trying to find out is which types of people get more sick. I don't think we've seen that so far. That's certainly not something that appears to be important. And Francesco, I think from Italy, is sort of further ahead than us. So I don't think that's coming out that that's a more severe type at all.
Could I make a comment, Caroline?
Yes, go ahead.
So we've heard from Nikki that she's seen some patients, but certainly no great number of patients. And Francesco, that was shockingly good news since you're very close to Milan, where the infection is at its worst. And David, who treats probably as many or more ITP patients in the US than anybody now, has also not seen patients. Dr. Wu will talk to us from Beijing, but another leading Chinese hematologist says it's not been that in China, ITP either developing or getting worse has not been much of a problem either. And I've communicated with a hematologist in Brazil, and they really haven't seen a problem. So I wonder, and Steve, if you're still on, and Charlotte and Nikki especially, if you could comment, is it possible that any degree of, let's say, immunosuppression means that you don't seem to be more likely to get the virus, but if you do, could it be milder by having an effect to reduce the cytokine storm and actually almost being an advantage? Or is that too outlandish a suggestion? Steve, could you start with that?
It's a very good suggestion, Jim.
I think that's what we're thinking.
Right now, it is still a hypothesis, and it's one that I think only by following people longitudinally will we be able to identify, or in animal models. But the animal models are still a little bit cryptic for this.
So you mean there might finally be an upside to taking prednisone for ITP patients? As a follow-up, I know we've talked about immunosuppression, but maybe one of our ITP experts could talk about the specific ITP treatments that cause you to be immunosuppressed, because I think there's a lot of confusion around that. I've just received a couple of questions from folks who are watching this broadcast live who have said, I'm on Promacta, does that make me immunosuppressed? So I think there's some confusion around which treatments really cause immunosuppression.
Nikki, why don't you take that? And then Francesco, if you want to contribute. And please talk about rituximab also.
Oh no, please. I had a lot of conversations about this with lots of different people over the last few weeks, and we've not come to an answer. I mean, I think that, you know, the rituximab depletes your B cells, but not your plasma cells. So I guess there was an anxiety that perhaps you might be less likely to be able to respond to a new virus. Otherwise, I think patients who get rituximab don't tend to get lots more viruses. So I think you can argue it both ways. I think at the beginning, the people were considering that perhaps the T-cell mediated therapies, so azathioprine or MMF, might be more immunosuppressive, but I'm not sure that that pans out really. And steroids have always had a bad rap in infection-related sort of lung disease. That seems to be the problem with COVID-19. But again, I really don't think we're in a position to know anything at the moment. I think the types of patients who get ill will help us to some extent, but really, I'm not sure. I'm not sure we can say anything at the moment about that.
What I have learned by contacting the many colleagues, and is also my opinion, there is no evidence in better or worse to using rituximab or regarding patients having received rituximab in the last 6 months. But as a common sense, let's say fear, many colleagues will not start yet in a new patient or in relapsing patient will start rituximab. And this is true for ITP and also for other hematological disorders like some lymphomas.
A few other questions that we have. I don't know who wants to take these questions, but what about those who are in remission for ITP? Is there a risk if they get COVID-19 of it dropping their platelet counts and coming out of remission?
I don't know if you can hear me. I think the best way to think of that, as I understand it, is it's the same as any other virus. I think that was mentioned before. I think the important thing is that there does not appear to be a particular risk that COVID-19 is going to selectively make ITP worse.
And what about the risk of bleeding? Again, I know we kind of covered it before, but Mike from the ITP Support Association in the Netherlands sent us a question. She wanted to know about pulmonary hemorrhage of infected persons with low platelet counts.
Nikki?
Oh, wow. I don't know. I mean, I think there is a lot of inflammation that's happening in the lung, and that's where the disease is. I think there's some thrombotic issues in the lung as well. So I think that you would not want a very low platelet count if you had COVID-19. I don't think it's a prominent feature of COVID-19 lung disease, having thrombocytopenia. But I think certainly if you had a low count and you had the illness, you would need to be treated for that. But I think the coagulation system is complicated in this disease. And again, I don't think we have a good answer for that.
Could I make a comment? We need to go to Dr. Wu just to get her opinion in a while. But one last thing that Nikki, you mentioned that we had forgotten to bring up and that's the issue of thrombosis. And the fact that I believe, Francesco, I don't know if this is correct, but I heard a presentation from a pulmonologist in Milan who said they've incorporated low molecular weight heparin as an anticoagulant prophylactically in people with COVID-19 who are sick, and that they're seeing an incidence of clots, and they now screen for it routinely. Could you make some comments about that? And then we'll go to Dr. Wu.
Yes, of course. It is common practice in Italy to give low molecular weight heparin prophylaxis in every hospitalized patients according to guidelines for not, let's say, for bedridden patients. And this is applied to almost all patients that are also in intensive care units, including Milan. And there is also some limited data that heparin could help to, let's say, mitigate the inflammatory response. The question of thrombosis has been issued to me by the leader of the ITP center in Milan. And here to say that in that hospital, many patients with cardiac problems are admitted. It is a reference center. So this figure might be a bit inflated by the particular specialization of the hospital. What is known, that I think you, Nikki, and you, Jim, also agree to this, is that these patients, most of the severe patients have a complex coagulopathy that is something like to disseminate intravascular dissemination as a reaction to the hyper response of the immune system. And also there is a drop in platelet count, but not below, let's say, 50,000 or something like that, but as a laboratory test that is part of the complex hemostatic disorder that these patients have. So the issue is if this patient should have a very low platelet count, how to improve platelet count. At the moment, the orientation is to use intravenous IG in these patients.
Thank you, Dr. Rodegario. I also want to mention just real quickly that there is also a wonderful ITP patient support group in Italy. We have a website, globalITP.org, and if you go to the website, you'll see all of the support groups listed from all around the world. They have a lot of great information. So Dr. Rodegario, I know you work with Barbara very closely in Italy, so I do encourage people to check out their patient association. Dr.
Yes, certainly there is a good organization in Italy that is able to connect people in need of help with the major centers treating ITP, or is able to provide the right answer to these people. And the Italian people just have to look to Associazione Italiana per l'ITP or Italian Association for ITP. The chair is Barbara Laurencic, you know very well, and they will find out the website. Maybe Barbara is listening and send you the website address, or I may for you.
I think that it's important to recognize that under Caroline's leadership, PDSA in the United States has worked with, I can't remember if it's 28 or 32 countries, and has really been the leader of the International ITP Alliance. And while bringing the world together right now doesn't seem like such a good thing in a COVID-19 epidemic, on the other hand, bringing it together virtually seems like a great thing. And we have to thank her and the hardworking PDA staff for that. Let me turn to Dr. Wu. And Dr. Wu, I apologize because I know it's very late for you, and I didn't realize that Dr. Cooter would have to leave the call early. Could you tell us about what's going on with COVID-19, what went on in China and what's going on in your experience? You're in Peking, and Dr. Wu is the leading non-malignant hematologist in children in China. Thank you.
Thank you very much. I'm Dr. Zhonghui Wu from Beijing Children's Hospital, National Children's Health Center in China. So thank you very much, and my pleasure here to introduction something about my work, my life in China, in Beijing, also with ITP, with COVID-19. So I have prepared some slides. So,
Dr. Wu, just hit the share screen button at the bottom and then select the PowerPoint.
Okay, I know, yeah. Just wait a moment. Could you see this one?
While we're trying to get these technical issues fixed with Dr. Wu from China, I just wanted to mention something here. Dr. Wu, I received an email earlier today from Jane Liu, and she runs ITP Home, which is the ITP Patient Association in China. And I know she said that she works very closely with you and that you are one of the best experts on ITP disease. And she also talked about some of the things that they have done to support and educate their patients. And she said that, at least from their association standpoint, and I know that they help thousands of patients in China, she said that they haven't really received a lot of information of ITP patients getting COVID-19, and that they had a lot of tips for patients in China, that patients should always have common drugs on hand should get sick, should they get an infection, should they have a nosebleed, and different things that they can do to help themselves so that they don't have to go for a clinic. So I think, Dr. Wu, are you back now?
Yeah, thank you very much for Carolina's introduction. So here is my slide. I prepared some slide that is very easy to let everyone to know what I have I said. That is one poem that is 岂曰无益于此同袍. That is one poem 2,000 years ago. So that is wrote record for the 60 days for our days fight with COVID-19. Also, my life beginning, that is the old things beginning, that is 23rd January, that is before the eve of the Chinese traditional Old of You, that is Spring Festival. The COVID-19 come without warning. So government have been responding to the epidemic in an organized manner, and Chinese people have cooperated response to the government order. All of us stay at home. That means in the Spring Festival without any parties, even in families. So you can see that is very hard, very hard period for all the Chinese person. So you can see just in the period of the Spring Festival, that is the biggest festival in China. So you can see all of us have stayed. That is very that is very huge, a very hard period. So what we do? So from the first case of the COVID-19 was found in Wuhan. That is 18th December 2019. So 63 days ago. So what we do during this 60 63 days. So over the past 2 months, the epidemic has been evolving and affect anyone. So national travel restriction and all of us stay at home. Medical team went to the front line and donated money and all the donated supplies. So whole country stay with the people who in the worst affected areas together. So you can see that is national action. So more than 40,000 medical staff around all of the China from the different hospital, different area gathered together to the Wuhan that support them to do the medical service. So also our government have the deadline. So here you can see just the date that is 3rd March. We have the 7th version published for the diagnosis and management for the COVID-19. So epidemic control that in the 1st April. So you can see here is the published number in the 31 March. So you can see that is total in China. We diagnosis for the 81,518 confirmed and 3,305 died cases. So at that moment, you can see also in the end of the March, that is a lot of imported cases have been reported at that moment. That is 771 import cases in China, but no new confirmed cases were reported in Wuhan from that. So as I know, today I discussed with one of our colleagues from Wuhan. He said now Wuhan is everything is gradually to normal. So all the worker in the hospital. Hubei also have reported totally that is 67,801. So you can see here is the number. Maybe this number is stopped here and very slowly increased. The majority now increased number is import cases. So the life and working during COVID-19. Here you can see all of us, we worked at home. Also, we have a community management. Also, we have this action all around our community. So you can see here, epidemic in China is now under control. So that is the report in the end of the March. So you can see 0 new cases cities is in all majority of the cities. So you can see here the left figure that is the epidemic trend in nation, and the left right one this is epidemic trend in Hubei, that is core of the epidemic. So you can see that is a great increase, and then rapidly. So as all of us control, we have a very good control. So you can see the Beijing daily life now. Here is the photo. So you can see in the public travel, also in our living area, also in the street, order in the market. So that is the living now is very good. So another thing, the situation in Beijing, that is a total 410 cases were confirmed in Beijing, and 248 were discharged. 5 died, just 5 died. So you can see that here is in Beijing. The sanitary hospital in Beijing, that is one is Yuan Hospital. This hospital is 99 confirmed cases was admitted, and 51 cases were discharged. So a lot of them have used traditional Chinese traditional medicine. Another very famous is Yitan Hospital. Yitan Hospital that is have 133 confirmed patients, and all of them is very severe. So here also, Beijing also have a local medical work. We have also Xiaotongshan Hospital was renovated and put into operation in 16th March and 16 March to screen high-risk passengers to the capital and treat input mild and no severe SARS-CoV-2 infections. After China beginning experience increasing risk of import cases earlier in March.
Dr. Wu?
Yeah?
Wu, I apologize for interrupting you. Could you go a little bit toward ITP and say what you know about how the infection might have created problems either with new cases of ITP or worsening old patients who already had ITP, having them get worse? Could you tell us what, if any, experience is available?
Okay, I pass very fast. Okay. Here, ITP work. As you know, here you can see here is our outpatient department. Every day we do our traditional January regulated date for the ITP work. So you can see, but as we must to stay at home, a lot of patients and parents could not go to the hospital. So we have daily medicine. So we use this daily methods to treat them. We think that is same thing to treat the new patient and the old patient the same time. So here is the ITP charitable activity that is celebrated for the 5th Platelet Day. Platelet Day this day is organized by the Chinese PDSA, PDSA like you. Also ITP home in China. So here I am an expert to have a presentation about ITP in pediatrics. And also Dr. Zhao, you know, also another very famous adult hematologist for ITP. At that day, so you can see totally as this day, that is near to 17, that near to 7,000 patients together. So yeah.
Dr. Wu, I have a question for you. I mentioned earlier that I had received an email from Jane Liu, who runs ITP Home in China, and she said that they hadn't seen any ITP patients with COVID-19 in China. Have you seen any patients so far?
No, so I have for this presentation, I asked this question to the ITP Home. So Tongfei told me that they don't have some patient who is ITP cases. Also, I asked my colleague in Wuhan hospital. They said that is no very increased the patient who is ITP to suffer the COVID-19. But he said if patient have required immune deficiency, maybe they easy to have COVID-19. Also, they have a very severe situation. Also, they will have the very high rate of mortality.
Well, thank you. Thank you, Dr. Wu. We still have our ITP experts, our other ITP experts available, and right now we have about 120 patient questions. I think we've been able to get to the majority of them. We can take a few more while we have everybody here. Dr. Holland earlier had mentioned the hydroxychloroquine. Everybody's been hearing about that as a potential treatment. However, Barbara asked the question, is that a quinine derivative and can it be safely given to ITP patients? Because of course we know that quinine can drop the platelet count. So Dr. Bussell, would you like to comment on that?
I think I would like to imitate Nikki in her own note response, but I think we really don't know. I think that's a brilliant question, but my suspicion is that it may not be the same, because I think quinine and quinidine are known to be related to immune thrombocytopenia with the drug contributing. I've actually not heard that ever with chloroquine or hydroxychloroquine. So I can't say it authoritatively, but I'm guessing no. Francesco or Nikki, do you have any comment on that?
No, no, I think, no, I don't know. I mean, hydroxychloroquine can be really helpful for ITP patients who are using that anyway. I think those are difficult, yeah, very difficult to question.
Yeah, I think now that you mention it, I realize that I think especially the French with Marc Michel and Bertrand Godot have been very active in using it in patients with ITP who have a suspicion of autoimmune disease. And they've published, I think, at least 2 articles on it, and I don't think there's been any concern.
So another question we have, and I don't know, Dr. Cooper, if you want to take this question as well. Of course, we have some very intelligent and sophisticated ITP patients. What about a cytokine storm? Are patients with autoimmune diseases more susceptible to this? This person wrote to us, I've heard this is what happens when a patient's illness becomes serious or life-threatening. So what is a cytokine storm?
Yeah, I think they're right. I think that is what's happening. I think that there is a certain time period in the illness that suddenly this cytokine storm happens. We don't know what triggers it, whether it's a reaction in the lungs to the virus or whether it's another infection or something happens. I don't think there's any evidence that patients with autoimmunity are worse on that. And I think what you have heard, at least from this group, is that we haven't seen worse disease in ITP patients.
Francesco, do you have a comment?
Yeah, about hydroxychloroquine, I had a correspondence with Marc Michel. She said that apparently is not so effective, but he didn't mention any drug-induced thrombocytopenia. Concerning pregnancy, in Italy, we have got some pregnant women hospitalized for severe COVID-19 disease. The neonates were born in good status, and what is important, all neonates were not positive to COVID-19, so there is not transmitted to the fetus or the baby. This virus is not transmitted through the placenta.
This is a general question, not necessarily specific to ITP patients, but this is from Trish in the Chicago area. Is there any validity to the theory that certain blood types handle the virus better than others? I've read a few times that type O doesn't react as badly as others, and that type A, I'm type A, is actually the worst.
I have no idea.
That's a paper from China, Dr. Wu. Do you know that paper?
That is not exactly, but some data show that is type A may be easier to infect, but type O is better. Type A is easy.
It was one study, cohort study, wasn't it? Just showing that a disproportionate number of people who were type
A.
what you would expect compared to Group O. So I think it's not a definitive, is it? I think it's just one paper suggesting it, and I guess that kind of data will be coming out more, I suppose. But I think it's not that something to be scared about, but I think it's definitely interesting.
So in Italy, we don't have this data. What many experts are saying, I don't know if there are data supporting this, is that the women are going better than male with COVID-19 disease.
I think we are going to need to wrap up. So let me first of all thank the panelists for coming in from all over the world. Dr. Wu, you're from the furthest away, and for providing us information that would not have been available at any one site or from just any one person. I think we hope there's a suspicion that at worst, there's no special risk if you have ITP to COVID-19. I think some of the things we heard at the end sound very interesting, but are in the category that we discussed before, where we're going to need more information. And I think you heard Dr. Holland point out the need for randomized controlled trials. I think we need to thank our Arthur, our Zoom tech, and Jeff Cooper especially for making this technically possible, and the PDA staff for pulling this together in an astonishingly short period of time. And let me turn it over to Caroline, who has spearheaded this.
Well, thank you again, Dr. Bussell, and thank you to all of our presenters. And PDSA is recording today's live event, Facts Over Fear, COVID-19 and ITP virtual town hall with global ITP experts. It'll be available on the PDSA website. We'll also have a highlight of the questions and answers available in our exclusive quarterly newsletter, the Platelet News, which is for PDSA members. So if you're not a member, please go to the PDSA website. I encourage you to visit that and become a member. We also have many other resources for you on the PDSA website, and we'll continue to update our COVID-19 hub, so continue to check pdsa.org for updates. Our monthly e-newsletter also has the latest ITP research, including COVID-19 updates. So we encourage you to sign up for the e-news if you don't already receive it. And then finally, we've heard from a number of patients who are concerned that the COVID-19 pandemic will impact the pharmaceutical supply chain and they will not be able to get their medication. PDSA works very closely with all of the pharmaceutical companies, our industry partners. So if you have a concern, please contact the PDSA office. We can try to help you with those issues. We also have a booklet on our publications page, Health Insurance and Assistance Programs for ITP Patients, where we list all of the companies who have programs who can financially support you. We've also translated many of our educational booklets into other languages. So for those outside of the US and Canada, again, I encourage you to go to globalITP.org website, where you'll find a list of, as Dr. Bussell mentioned earlier, there are 32 ITP patient associations from 27 countries, and they're listed on that website. So we encourage you to check that out as well. And again, I'd like to thank all of our presenters, along with Dr. Bussell, the PDSA staff, and our sponsors for making this program today possible, argenx and Dova Pharmaceuticals. And most of all, I would like to thank you, our ITP community of patients and caregivers. Having ITP myself and having another immune issue, I know that this is a really scary time for everyone, but I want you to stay strong, stay healthy, and know that you're not alone. PDSA is always here for you. Thank you so very much for joining us today.